your recommendations and the questions you've posed, and I thank you for it. Dr. Glover.
Thank you, Mr. Chairman and members of Congress, for the opportunity to share with you. My name is Dr. Frank Glover, and I'm a board-certified urologist. I earned my MD degree at Johns Hopkins, and also the Doctor of Public Health and International Health Systems. I've also done some work as a research fellow at Johns Hopkins in epidemiology. I'm also a medical missionary working with SIM, which is a Christian missions organization with works in over 60 countries. In addition to working with SIM, I'm the president of SHIELD in Africa, a U.S.-based NGO working in Liberia. My first experience in Liberia was in 1988 when, as a medical student, I spent 2 months doing medical missionary work in an SIM hospital called ELWA, Eternal Love Winning Africa. For the past 3 years, I've spent 4 months per year working in various hospitals throughout Liberia. I've taken teams of up to 50 doctors and nurses several times per year. During this time period, we have taken care of thousands of medical and surgical patients. I've spent time rendering services of teaching, training, and patient care in most of the counties in Liberia. I have, therefore, had the opportunity to assess many of the hospitals and clinics throughout Liberia. In every case, the hospitals were understaffed and lacking in many basic essentials and pharmaceuticals. This Ebola outbreak in Liberia has exposed the country's inherently weak health system. Less than 200 doctors existed in this country of 4 million prior to this epidemic. After the outbreak in March of this year, that number plummeted to only 50 doctors. This occurred as a result of the exodus of 95% of the expatriate doctors. Prior to the Ebola outbreak, the nurses went on strike or slowed down work throughout the country due to work grievances. This was true in Lofa, Bong, Bomi, and Montserrata counties, which have been hit hardest by the epidemic. These nurses returned to work after negotiations with the Ministry of Health just before Ebola entered the country. After the outbreak began claiming the lives of the nurses who did not have protective gear, the nurses fled the hospitals. After a second Liberian doctor died of Ebola, all of the government hospitals shut down. The patients are too terrified to enter the buildings. The nurses have stated they will not return to work unless they're issued adequate protection, including gloves, gowns, and goggles. At the ELW hospital, in conjunction with Samaritan's Purse, doctors and nurses continue to treat Ebola patients. There are 5 doctors and 77 nurses and aides. This is the only place in Monrovia where treatment for Ebola takes place. Currently, there is only enough space for 25 patients in the isolation center. Initial attempts to expand the unit were met with protests from the local community, which did not want Ebola patients coming from all over Liberia into their community. Having allayed the fears of the community, Samaritan's Purse will complete an 80-bed unit in the next 2 weeks. The only other treatment center in Liberia is a 40-bed unit in Lofa County. The case fatality rates range from 80 to 90% at both facilities, owing in part to the delays in people seeking treatment. Many patients die within 24 hours of presentation. ELWA is the only functioning hospital in Montserrata County, a population of nearly 1 million people where Monrovia is located. Many patients are dying with Ebola in their communities, in part because there are simply no open health facilities. This creates problems because whole families are getting infected and dying. There is no way to count all the people dying of Ebola in the villages and in the remote areas. The cause of death is often unknown, and there exists a lot of suspicion toward Western and government health workers. As a result, information is often withheld from health workers. Advice on safe burial practices or abstaining from eating bats and monkeys is oftentimes met with resistance and even violence against health workers. To complicate matters further, usual illnesses such as malaria, typhoid, pneumonia, and surgical emergencies result in death, as there are no functioning facilities at this time. The death toll will undoubtedly reach into the tens of thousands in Liberia unless immediate actions are taken to, 1, increase the capacity to treat patients in isolation. 2, create an effective means of quarantine for those suspected of having been exposed to Ebola. And 3, provide protective gear to all healthcare workers and those involved in disposing of the bodies of patients that have expired. Given the episodic nature of Ebola, we must begin investing in healthcare system strengthening as we prepare to deal with future outbreaks. SIM and SHIELD stand ready to assist in the building of capacity of West Africans by training and producing more African healthcare professionals. Thank you.
Thank you so very much, and for your lifelong commitment and for building up capacity and doing it yourself in working with others at SIM. Let me ask you just a few questions, because your testimonies, I think, were very comprehensive. You said, Mr. Isaac, that the international response, you deemed it a failure. And of course, no failure need be a failure in perpetuity. And I'm wondering if there has been a turn of the corner, again, inspired by the tragedy of 2 of your workers being affected by the Ebola virus. And secondly, could you tell us how they're doing? How are their spirits? Whether or not there's a sense, even if it's it's not fully backed by science yet, that the drug ZMapp may have had an impact. I think, one of the questions I asked of the earlier panel, if some of these interventions prove to be efficacious, delay is denial if you have Ebola. And since this seems to be ramping up and not ramping down currently, your thoughts on an aggressive FDA working in cohort with, in conjunction with the other agencies of government to get, based on an opt-in, of certainly recognizing the risks, as Dr. Brantley certainly did, and Ms. Whitehall.
So on the failure aspect, I would say that I think the full international Ministry of Health status reports that come out every day from Liberia. I don't mean to be dramatic, but it has an atmosphere of apocalypse now in it. There are bodies lying in the street. It's on the front page of the Wall Street Journal. And today, there are gangs threatening to burn down hospitals. And this is essentially a society that is, let's say, a generation from everybody had post-traumatic stress disorder from a horrible war. They can go from a normal conversation to a fist fight to sticks in a flash of an eye. So they have a lot of temperament, and they have a lot of investment in what is going on. There's a lot of emotion. But it isn't just Liberia. It's Sierra Leone. It's all of these countries. What would happen, I don't want to, you can use your own imagination in Nigeria, Lagos. What could happen there? And I believe that this disease has the potential to be a national security risk for many nations. And I think it will have an impact even on our national security. It has been a failure because it's now jumped another country. Because the epidemiologists have totally misread the magnitude of the disease, and because there are not resources on the ground. The status of the 2 patients, I can say that I hear from Emory the same thing everybody does. They seem to be getting a little better every day. I do not think this will be a fast process. After that medicine was administered, after it was brought to us by the NIH people, and Dr. Brantley was very much involved in giving his informed consent to it. He understood, as did Nancy Whitehall. There was improvement, and I think, as the doctors were saying here, I'm not a doctor, I don't want to guess at science, but I will say that they seem to have gotten better. They got home. They're in Emory. We appreciate Emory. They're getting good treatment there, and we just pray that they survive and can recover their health.
Let me ask you, you pointed out 4 different areas: kissing the corpse, community health workers, medical professionals, as 3 of those. Now, let me ask you about the community health workers. You pointed out that in one cluster of infected individuals, 8 out of 12 were community health workers. Now, doctors obviously have a higher degree of training. They understand the essential importance of protective garb, and community health workers might not have that same level of indoctrination about how important that is. In your view, are they much more at risk because they are more rudimentary in what they do, therefore they're not taking the precautions?
So, in my view, yes, they are more at risk. It's not just to do with the personal protective gear, but it's also to do with the lack of education. If you look at the symptoms of the disease, fever, joint pain, vomiting, and diarrhea, I'm going to guess that probably covers 50% of all the diseases that present to them. That puts them in an untenable and weak position of being exposed to the disease and not exactly knowing what it is. I just am saying that I think that there needs to be focused education efforts on these 4 levels of society: general public awareness, community health workers, medical professionals, and national leaders. That each one need, like I don't think putting a poster up on the wall saying Ebola kills is going to do it. I think that there has to be a programmatic approach to each one of these stratas of society to get the essential information that they need to encourage people from their position and to deal with the things that come to them.
I have been advised, Doctor, please.
Yeah, I would take a slightly different take on it. I believe that community health workers, if properly trained, can get the same outcome of coverage as physicians. What we have to understand is that health workers don't get Ebola because of carelessness necessarily, or because of lapses in sterile technique. In the case of these workers, for example, it's very likely that they contracted Ebola from other workers who were at the hospital who may have gotten the disease from the community. So if you're working alongside someone and they happen to have Ebola, then you get it from the staff. And so there are a number of documented cases of staff infecting staff. In fact, just yesterday's report in Kakata in Bone County, where 4 nurses died and 11 more were infected. And so there's a lot about the infectivity that we don't realize in terms of how it happens.
Let me just say, in terms of getting the message out in a way that will be most likely received so that people understand the catastrophic nature of the disease, my understanding is that Guinea today is recruiting retired doctors, nurses, and midwives, authority figures, older rather than younger, to convey this message. Have you heard that? And are the other countries, the other 2 countries, and perhaps even Nigeria too, looking to do that so that authority figures convey, again, the paramount importance of, for example, burial practices and the like?
Yeah, one of the challenges we have in Liberia is after this 14-year brutal civil war, during that period of time, people did not go to school. So you have a large population of illiterate people, and many of the languages in Liberia are not scripted. So you can't write something. So there needs to be language appropriate in each dialect in a way that each community can understand it so they can get the message. So it requires people that are seen as authority figures, but also people that are able to communicate in the person's spoken language so they're able to get the message. So as he says, putting a poster up is not going to help someone when you've got an illiteracy rate of 75%.
Finally, just let me ask Mr. Isaac, if you could. You said that the president of Liberia was a month late. Is it too late? And what would have happened had that state of emergency been declared a month ago?
The month statement was not a scientific statement. It's just an opinionated statement. And when I don't have knowledge, I always have opinions, rightly or wrongly. But I do think that Liberia would have been better served had a status of emergency been declared earlier. Now, I don't know all of the actual mechanisms that will go along with that declaration, but it is clear to me that Liberia is in a severe crisis that I believe threatens the stability of society as it exists today. And I think that as you see the disease spread in Freetown and in Conakry, hopefully it's peaked there, and in Monrovia, you're going to see more instability and insecurity.
Let me ask about the question of testing. And you heard the exchange earlier with Dr. Frieden and other members of the panel about the lack of labs, lack of testing capability. Even in if you might want to comment on that, but even in the best of circumstances, say in New York or New Jersey, how long does it take to get a test back? Because this does move very fast.
Well, we have special tests in the U.S. that are just a matter of a few hours. But logistically, when you look at the infrastructure of these countries, to go from one point to the other on the map, it may look like, oh, it's just 50 miles. That 50 miles could take you 8 hours because you can only drive 3 miles an hour through roads that are impassable. So a lot of logistical problems here. But I believe the number one cause of healthcare worker infections in Liberia is the lack of the protective gear. They're asking people to go to work to take care of patients, and they don't have gloves. And to me, this is unconscionable. So if we're going to put people on the line, the brightest and the best people in the country on the line, we owe it to them to give them a fighting chance. Even in this country, no matter how well-trained a doctor is, if an Ebola patient comes up to him before he or she knows what he has already been infected.
Mr. Isaac, you asked the question earlier, where will the money go? What will it buy? Where, in your opinion, should the money go, and what should it buy?
So I sort of feel that I think that international personnel are needed. I frankly do not think that the Ministry of Health of Liberia can fight this. They do not have the case investigation capacity. I talked with a senior person in CDC. I won't name her, but she's a well-known person. She told me that in the United States, if there was one person that had a level 4 infectious disease, they would have many hundreds of contacts to run down. There's no contacts being run down in Liberia. I don't believe that the Liberian government, as well-intentioned as they are, and I do believe that they're well-intentioned, I just simply do not think that they have the capacity. I am all for building the capacity, but I think there needs to be something to augment their capacity. I think that there needs to be some kind of a coordination unit. I have heard here today that the World Health Organization has the lead. Maybe, maybe not. I think that probably something with a bit more of an operational edge to it is called for. That may be some kind of a, I don't know what that could be, but more is needed. And I think that if we leave this situation up to the ministries of health, you have a unique situation where you have 3 poor countries that have a communicable, infectious, and lethal disease that clearly don't have the capacity to contain it, and is the world willing to allow the public health of the world to be in their hands while they try to contain the disease? I think that's the essential question.
Thank you.
Yes.
And finally, Dr. Glover, you had worked on the DRC outbreak of Ebola, some 20 years ago?
Actually, I was, at that time, I was working in Zaire, in Kinshasa, but the outbreak was in Kikwit.
Okay.
So I was there during the outbreak, but I wasn't actually working with the Ebola.
How does this compare to that outbreak?
There is no comparison, because back then it was a very sparsely populated rural area where it could essentially burn itself out. But you have so many people in Liberia that have moved to the city so that they're living very close. If you look at a taxi cab or a bus, you wonder how could they get so many people jam-packed in there, or how many people live in a house, for example. So there was an instance at the Phoebe Hospital where the administrator came down with the virus, and he infected his 8 children and his wife, and all 10 of them died. So the close proximity that the people are living, the concentration of the population means that as this epidemic, no matter what we do, unfortunately there's going to be tremendous loss of life just by the nature of this disease.
Well, I thank you both. If there's anything you'd like to add before we conclude the hearing?
I would just say that I think much more, I'm certain there's much more than I know of, but this concept of research and development for a vaccine and a cure is very important. I agree with Dr. Glover. I think we're going to see death tolls in numbers that we can't imagine right now. That is potential. And also I will tell you that we are now, as Samaritan's person, in the process of distributing Ebola readiness information to all missionary hospitals across Africa.
Dr. Glover, any final words?
No final words.
Thank you. I want to thank both of you again for your extraordinary service to mankind, and especially to the sick and at risk and disabled and those who are suffering this terrible outbreak of Ebola. And we look forward, if you could, stay in touch with our subcommittee. This is the first of a series of hearings. We're looking to make sure that whatever we need to do as a Congress and as a subcommittee, and me personally and my colleagues, we want to do. And again, your guidance is absolutely essential. Thank you for sharing your wisdom and insights and incisive commentary to the committee. The hearing is adjourned.
Thank you.